Good afternoon. Welcome to San Diego. It's the International Workshop on Non-Hodgkin Lymphoma. And we've just had a session on mantle cell lymphoma, and I'm joined by my friends and colleagues here, Constantine Tam from Melbourne and Mary Callanan from France. So, Con, we were talking about the context of Ibrutinib failures. You gave a very interesting talk about the importance of Ki67 and blastoid variant, how these patients clearly are different from a biological perspective and a clinical perspective. Would you like to just outline why you think those groups of patients do badly, and then perhaps touch on the trial you're doing in Australia, the AIM trial, which is fascinating?
Sure. So we looked at the historic data, what's been published on mantle cell lymphoma, and it's pretty clear that there is a group of patients who do disproportionately badly, no matter whether they have chemotherapy, targeted therapy, or autologous transplantation. And these patients are described variously as those who have blastoid histology, or those with high Ki67. And really, I think those patients are tied up together. You know, in a lot of the studies, they co-correlate together. So patients who have blastoid histology are the ones who have got high Ki67 fraction. And certainly from the big European studies, it's pretty obvious that the patients with a high Ki67 fraction are the ones who do poorly. So I think rather than rely on a sheer cytomorphology way of assessing these patients, maybe a way to objectively assess these patients on clinical trials is in fact to look at their Ki67 expression. We then speculate on why these patients do have a high growth signature, and as data from yourself and others have shown that patients with mantle cell lymphoma may be becoming quite reliant on the NF-kappa B pathway, and that a lot of these patients certainly have dysregulation of the NF-kappa B pathway, and patients who are chemo-refractory, who relapse from transplants, and now emerging data suggests that patients who actually do not respond or who relapse on Ibrutinib are those who have got mutations affecting this pathway. So adding the whole package together, this whole concept of a proliferative mantle cell lymphoma with mutations in the NF-kappa B pathway, I think will be our most challenging subset. These are patients where I don't think any of us know what the proper therapy for them are yet, but clearly these patients needed something different. I was actually fascinated by your study of the early allogeneic transplant data showing a very good outcome in patients who've got blastoid morphology, and maybe that's the way we need to move forward. Specific to our AIM study, this is a study combining Ibrutinib and ABT-199 for treatment of mantle cell lymphoma. So this is very early data. We've just finished enrollment to our study. We presented some data to show that the combination is feasible, that we don't think, at least based on our experience, that there is enhanced tumor lysis syndrome with the combination. We've certainly seen very high rates of complete remission, very high rates of MRD clearance. So the final data set will hopefully be mature enough to be reported in about 4 to 6 months' time. And in addition, the molecular correlate studies that accompany AIM have shown some really interesting data with identification of mutations that we would normally predict to be resistant to Ibrutinib. And certainly we've had patients who appear to have had a fairly ordinary response to Ibrutinib carrying one of these mutations, who then responded well to the combination, and conversely patients who have had no response at all to either of the two drugs when they carry these mutations.
So it's a very rational thing to do, and you've showed high levels of MRD negativity, and I guess thinking how we're going to move forward, the idea, I guess, is we're going to have to stop these drugs because it's going to be financially too toxic, I guess. Which brings me on to Mary, and we're talking about MRD. You showed very nicely MRD levels around autologous stem cell transplantation within the LYSA trial. Some complexities with MRD, of course. Do you want to touch on the sort of the differences between blood and bone marrow, and what's the right way to do it? Because as you rightly said, we spend a lot of time assessing statistical analysis of trials, and yet we don't get MRD assessment done terribly rigorously.
So I think that the complexity of building MRD studies into clinical trials relates to issues concerning sample collection, standardized methods, and so on. So maybe, this complexity, I think, though, has been relatively well handled in one sense by efforts internationally, and particularly in Europe, to standardize pre-analytical steps, to standardize methods, qPCR being the mainstay of the MRD assays in the Lyma trial, which is run by Stephen Nguyen and Olivier Armin for the LISA group. So I think that the complexity is there, that's for sure, but huge efforts have been made and progress has been made in standardizing things so that people can speak more or less the same language, at least within a trial, which is already a big achievement, and also across trials possibly in the near future. So now coming to the sampling compartment, Simon, you're correct. This is not a trivial issue. I think that first of all, let's take it from the patient's point of view. They are, probably better spared analysis in bone marrow compared to blood. I think the good news from the Lyma trial, at least under high dose or chemo autologous stem cell transplantation and followed by maintenance or not, the good news there is that our data suggests that MRD status in blood post-induction and post-autologous stem cell transplantation, those 2 time points are highly predictive of at least PFS. So that's good news. So that would suggest that blood MRD analysis should be done as systematic. Maybe it's too soon possibly to leave out bone marrow, so we're holding on to that at that end of induction phase, and also every year during maintenance or observation, depending on the trial. So I think that moving forward from that, certainly it's not, within the remit of the question. I think that future directions, at least in the LISA group, and I'm hearing at this meeting in San Diego that many other groups are thinking along the same lines. My neighbor here with the circulating tumor DNA, there are different concepts emerging, but I think everybody agrees that these things need to be done. And then within the LISA group, coming back to our group specifically, the French group, we have used the Lyma results, interim analysis, plus the EU Mantle Cell Lymphoma Network results with Christiane Pot to build a trial where we use MRD to guide what we call maintenance on demand with an anti-CD20 maintenance strategy with GA101. So I think that we're cautiously, maybe conservatively moving forward to decision clinically, decisive decision driven MRD.
Taking it out of the trial scenario, putting it into the real world where we can actually act on it.
That's right. Maybe I could add, it's possibly slightly off the topic, but I could add that certainly in Europe, I'm not sure how the NHS in the UK stands on this, and I can't speak on the American health authorities, but certainly in Europe and in France in particular, there has been a very, very energetic drive to make these tools available as standard to patients with mantle cell lymphoma in certain indications. So there will be reimbursement of those tests. The tests are proposed by expert panels, and those tests will be reimbursed, so patients don't have to pay. And this, I think, is a huge leap forward.
We're not there with mantle cell, we're there with acute lymphoblastic leukemia. So yes. I think as the evidence becomes clear that you're going to make clinical decisions, then that will emerge. Yeah. So I'll just briefly touch on one. I was given the slightly difficult task of discussing what you do in patients that fail Ibrutinib, which is an evidence-free zone, of course. And just briefly, the historical context is patients that failed on Ibrutinib did spectacularly badly. We all saw that. You'd stop the drug and they'd relapse explosively. Nothing worked, and their life expectancy was really very short. It's becoming clear, I think, that that's a historical perspective, that the first patients we ever treated were the worst patients. Yes. When they relapsed, nothing really worked. And the data from the RAY trial suggests that at relapse, if you're using the drug earlier, then it's easier to get people into remission. What you do is the question, and I was very interested because I asked you specifically about ABT199, that you would hope that would be the drug that would be the best option, and you really didn't like it. I mean, I just explored the various chemotherapeutic options you might use, including bone marrow transplantation, which I think increasingly, we put conventional treatments to one side as we get exciting new drugs, but yes, they're still there and they still work. But now it's a bit, we've talked about this before, it's a bit disappointing really that post-Ibrutinib, some of the novel drugs aren't that active.
Yeah. So, I mean, at least in our limited experience, we haven't had much success with ABT199 in people who progress through Ibrutinib. But what I thought was really interesting about your analysis was, this concept that chemotherapy, is probably not going to be departing us anytime soon. Patients do fail Ibrutinib, and then trying to marry the biology of what we know about Ibrutinib failure and the choice of chemotherapy. What are your thoughts about what you've seen from the mutational data from Ibrutinib and what you know about chemotherapy? What are your thoughts about the optimal choice?
I'm not really sure. There's no clear pattern with these the mutations. They're only one particular pathway. I mean, they're in the alternative NF-kappa-B pathway predominantly. So I don't think it readily lends itself to any particular chemotherapeutic option. I mean, as I mentioned, NIC inhibition might be a smart thing. You can see there are mutations down there, but that's a way off. I mean, these drugs aren't even in clinical development yet. No. So I think what will happen is, we will just try and see which drugs work, because mutations are all over the place in these patients. So I don't think you can personalize it really. See the mutation, that equals drug X. Yeah. When the tools we've got are pretty blunt, aren't they? I think the point I made at the beginning was that chemotherapy works, and we have to remember that. So I guess just to come full circle, your AIM trial is great. I'm doing a similar trial with Steve Laguil, as you know, we're adding an antibody. Ultimately, we're going to stop, and we're going to stop based on MRD. So the question is, where do you think we should stop? Yes. How long should we have somebody MRD negative before we stop? What would you recommend? Because we don't know.
That's the question, isn't it?
That's what I'm asking you.
That's the burning question. Absolutely. So I have to tread carefully, because I think, again, what's for sure is that, this maintenance therapy, once you're getting activity, and this is continued purging activity, achieving molecular remission is certainly moving forward as something that's becoming more than a secondary objective, I think. Now, this is where I have to go to what I'm looking at from the imaging world, clinical response criteria. And I'm not skirting the question, Simon. What I'm trying to say is that I think we don't have enough data just yet to be able to tell you with absolute certainty that once you have 1 year molecular disease-free, or 6 months molecular disease-free following a minimum of X years of maintenance, where we are sure that purging has occurred. I'm not sure we're there quite yet.
But that's a different trial, because you're giving chemotherapy followed by an antibody. We're talking about novel combinations here.
Oh, I beg your pardon.
So we don't know what that means.
Oh, you mean upfront? You mean okay? Let's clarify the issues here then. So what you're looking at is novel agents. I understood the question.
The combination Con's using,
right?
And the one I'm doing with Steve.
How deep do we go, and how long do we need to maintain the deepness for before we think maybe it's safe to stop?
Well, I think this question, we don't have the answer yet. I don't want to kind of mix our metaphors here, but let's go and have a look at CML for a moment, chronic myelogenous leukemia. They got to the point where they, stop TKI trials. Yes. So they were very conservative. So what they wanted was, the first question is to define molecular remission, and how long that molecular remission should be, how long should it be there for before stopping drug. So I think we're going to have to look at those questions progressively, and possibly maybe the LISA trial might help. I know it's, again, a very conservative, and it's not the question that you're asking, but certainly I think that in the maintenance setting, we're close to understanding what we should do. I think it's too soon upfront to drive a clinical strategy unless it's not too, in the lower risk group possibly. MRD could be used to...
Except that we're going to have to do it at some point.
I agree, but this is where I can come back to you, Simon. I think that in lower risk groups with MRD negative, there could be an argument to wait or delay, or so which is coming back to the UK study that you're doing.
Yeah, hard to define what a low risk group is, I guess, but anyway. So
Well,
we'll have to wrap up there. So
okay.
Thank you very much. So that's us in San Diego. Plenty of questions, not many answers. Thanks very much.